Good evening to all of you. And thank you for the SAPEN for organizing such a unique topic. And we all are looking forward to hear our excellent speakers. Without much delay, I would like to introduce our first speaker, Dr. Harshini Sapramadu. She's a consultant nutrition physician at the District General Hospital, Matara, Sri Lanka. Dr. Sapramadu obtained her Bachelor of Medicine, Bachelor of Surgery degree in 1996 from the Faculty of Medicine, Ragama University in Kelaniya. After completing her undergraduate studies, she served as a medical officer in various regions across Sri Lanka and gaining invaluable clinical experience. In 2013, driven by her passion for nutrition and patient care, Dr. Sapramadu pursued a postgraduate care to further specialize, and in 2021, she successfully completed her MD in clinical nutrition. Dr. Supramadu further honored her expertise through overseas training at Sanford Royal Hospital, Manchester, United Kingdom, where she expanded her knowledge and advanced clinical nutrition practices. Upon her return, she obtained board certification to practice as a specialized in clinical nutrition in Sri Lanka. Currently, Dr. Sapramadu continues to provide expert care and guidance in nutrition at the District General Hospital, Matara, contributing to the well-being of the community through her extensive experience and dedication to the patient-centered care. With all the beautiful introduction of Dr. Harshini, we would like to invite you and over to you, Dr. Harshini, for the session today. Thank you so much.
Thank you very much for the kind introduction. Today, I'm going to give a small introduction on morbid obesity and pharmacological management of obesity. So, as we all know, morbid obesity is a severe form of obesity characterized by a BMI of more than or equal to 40 or BMI of more than or equal to 35 with obesity-related health complications. In 2025, the Lancet Diabetes and Endocrinology Commission proposed a new diagnostic approach, and that focuses on the measurement of body fat and objective signs and symptoms of ill health. So according to this classification, there are two categories of obesity: preclinical obesity and clinical obesity. So there are a few limitations in the current definition. It does not directly measure the body fat, and it does not establish the distribution of fat in the body, and it also cannot determine when excess body fat is a health problem. In preclinical obesity, there is excess body fat, normal or high muscle mass, normal or low muscle mass with no clinical signs and symptoms of obesity-related health complications. In clinical obesity, in addition to the excess body fat and normal or low muscle mass, there are signs and symptoms of obesity-related health issues. So in the management of preclinical obesity, that focuses on risk reduction and prevention of progression to clinical obesity or other obesity-related diseases. And clinical obesity management focuses on improvement or reversal of organ dysfunction. So when we come to the medical management, anti-obesity medications are indicated in individuals with a BMI of more than or equal to 30 or more than or equal to 27 in the presence of one or more comorbidities. So medical management targets the enzymes and hormones implicated in the pathophysiology of obesity. These targets include lipase, which is an enzyme involved in fat digestion and absorption, glucagon-like peptide 1, a hormone that promotes postprandial satiety, leptin, which is a key regulator of the hunger, and the melanocortin 4 receptor, a G protein coupled receptor that regulates the energy homeostasis. And the first one, lipase inhibitors, it acts by reversibly inhibiting lipase, thereby blocking fat digestion and absorption, and it acts via intestinal wall. The famous Sendo's clinical study has found, in addition to the improvement of body loss of body weight, it has other effects such as blood pressure improvement and reducing the incidence of type 2 diabetes. This slide shows a comparison between Orlistat and the placebo on efficacy of parameters at 24 weeks. We can clearly see the changes in weight, BMI, and waist circumference among the individuals given Orlistat. Orlistat is the trade name of one of the trade names of lipase inhibitor. So this I have extracted from Journal of American Medical Association. It's an randomized controlled trial done on obese adolescents. As you can see, there is a statistically significant difference in body weight, BMI, and waist circumference among the Orlistat treated group. Also, we can see there is a statistically significant number of participants in the Orlistat treated group was able to achieve 5 to 10% loss of BMI and the body weight. So possible side effects are the oily spotting, flatus, fecal urgency, and fecal discharge, fecal incontinence. It is contraindicated in pregnancy, chronic malabsorption syndrome, and cholestasis. The next one is the GLP-1 receptor agonist. As I said earlier, it's a peptide hormone produced by the intestinal epithelial cells in response to meal intake. And it functions as a natural appetite suppressant because it decreases gastric emptying and reduces intestinal motility, signaling a long amount of postprandial satiety. And it also takes part in the ileal break, which is a negative feedback mechanism, optimizing nutrient absorption and digestion, helping to reduce the body weight. So it functions. It functions. Also, it functions contributing to regulating the blood glucose level, and it helps not only weight reduction but weight maintenance also. This is a summary of the organs where the GLP-1 acts. In addition to the appetite, insulin resistant, improvement of peripheral insulin resistant, it also has actions on the cardiovascular system, improving the myocardial contractility and improving the ischemic preconditioning, and also improving the endothelial function. Also in the kidney, it increases the sodium excretion and causes diuresis. So in addition to body weight reduction, it has an effect on blood pressure reduction, plasma glucose reduction, and plasma lipid reduction. Exenatide is an example of GLP-1 receptor agonist. This was approved by the FDA for the treatment of type 2 diabetes because of its action on increase in insulin secretion from the pancreatic beta cells and decreasing glucagon secretion. It also has this delaying gastric emptying, increases satiety, and reducing food intake also. Although there are effects, the exenatide promotes weight loss, it is currently not approved by the FDA specifically for the obesity treatment. The second drug is the liraglutide. It is approved initially for the management of type 2 diabetes in 2010. And in 2014, FDA approved it for the management of obesity under the brand name of Saxenda. And in 2020, this was approved for chronic weight management among pediatric patients also. So this is given as a subcutaneous injection, once daily dose. So this slide shows the results of a randomized double-blind trial done among individuals with pre-diabetes, which I have extracted from the Lancet. We can clearly see the drastic weight reduction in the liraglutide-treated group. Side effects, possible side effects are the pancreatitis, then gallbladder problems, and hypoglycemia in type 2 diabetic patients who are on other anti-diabetic medication. And it is contraindicated in pregnancy, acute pancreatitis, and if there's a history of medullary thyroid carcinoma or multiple endocrine syndrome type 2. The third GLP-1 receptor agonist is the semaglutide. It is approved for the treatment of type 2 diabetes in 2017 and under the brand name of Ozempic. And in 2021, it was approved for weight management under the brand name of Wegovy. So it is given as a once daily subcutaneous injection, initiate with 0.05 milligram per day and escalate every 4 weeks. This slide shows a study which shows the semaglutide has a good, in addition to the semaglutide has a better weight reduction effect than the liraglutide. The side effects, possible side effects are again the pancreatitis, gallbladder problems, then hypoglycemia in patients with type 2 diabetes who are on other anti-diabetic medication. It is contraindicated again in acute pancreatitis and if there's a history of thyroid medullary carcinoma or multiple endocrine neoplasia syndrome type 2. Tirzepatide is a new drug. It is a combination of GLP-1 receptor agonist and glucose-dependent insulinotropic polypeptide receptor agonist. GIP acts by stimulating insulin release, improving insulin sensitivity, and when combined with GLP-1 receptor agonist, it contributes to weight loss by reducing appetite and promoting satiety. It has a long half-life of about 5 days, so it is given as once a week subcutaneous injection. Tirzepatide is currently approved by the FDA for obesity management. Then the other drug is leptin analog. Leptin is an adipocyte secreted hormone which plays a role in nutrient homeostasis and satiety. It is commonly known as satiety hormone. But this is indicated only in patients with obesity due to congenital leptin deficiency. Because in other causes of obesity, their plasma level of leptin is already higher than in lean individuals. So that suggests leptin resistance. So there is no effect in inhibiting food intake by the exogenous administration of leptin. So these leptin analogs are indicated in congenital leptin deficiency patients or in congenital acquired generalized lipodystrophy cases. The possible side effects are increased risk of lymphoma and again hypoglycemia in type 2 diabetic patients who are taking other anti-diabetic medications. And it is, as I said earlier, it is indicated only in congenital leptin deficiency patients. Then last one is the melanocortin 4 receptor agonist. It's a G protein receptor and it is encoded by the MC4R gene. So when activated, the MC4R receptor, it reduces appetite, it reduces the appetite, and it is ideal therapeutic target in individuals with obesity who have MC4R gene mutation. Possible side effects are sexual dysfunction, depression, and increased skin pigmentation. And as I said earlier, it is indicated only in patients with MC4R gene mutation patients. The drugs such as phentermine, topiramate, sibutramine, and leucoserine were used earlier for the management of obesity, but it's no longer popular for the management of obesity. So this is a small summary of all 4 drugs I explained earlier. So then this is a study done in 2023. The Journal of Endocrine Society has published this study. They have measured 5%, 10%, 15%, and 20% weight loss by giving different anti-obesity medications. We can clearly see in all 4 categories, highest percentage of participants who have achieved the targets are from the semaglutide and tirzepatide treated groups. So these are my references, and thank you very much for listening.
We will be moving to our next presentation. I would like to show his picture before we start with this presentation. So our next presenter is Professor Ishan D'Souza. Professor Ishan D'Souza is a professor in surgery from Faculty of Medicine, University of Colombo, and an honorary consultant surgeon of the National Hospital of Sri Lanka. He graduated from the Faculty of Medicine, University of Colombo, Sri Lanka in 1992. He completed the Master of Surgery from University of Colombo, Sri Lanka in 1999. He obtained both fellowships of the Royal College of Surgeons of England and Royal College of Surgeons of Edinburgh in 2000. He was board certified as a gastrointestinal surgeon in 2002. Professor Ishan D'Souza was awarded a fellowship of College of Surgeons of Sri Lanka in 2013 and an honorary fellowship of International Society of Coloproctology in 2014. He obtained Doctor of Medicine by thesis from the University of Colombo in 2017. He is the president of Colombo Medical School Alumni Association. Professor Ishan is a past president of Sri Lanka Society of Gastroenterology and Faculty of Medicine Teachers Association of Colombo. Professor has over 45 publications in peer-reviewed journals and over 100 published abstracts. He has authorized 2 chapters in the textbook of gastrointestinal surgery and won 9 Best Paper Awards for the research presentations and National Research Council Award for publications in 2016. His surgical and research interests include diagnostic and therapeutic endoscopic advanced laparoscopic surgery, colorectal surgery, upper GI bariatric surgery, and metabolic surgery. And without further ado, I would like to invite Professor Ishan D'Souza with your presentation, sir. So we are very glad to have you here.
Thank you for those very kind words of introduction. Let me just share my screen. So, good evening to all of you. And sorry for that little delay. I was asked to speak on an overview of surgery for morbid obesity. Next slide, please. Right. So generally people who have a BMI of over 35, at least in our populations, are considered to be morbidly obese. And generally to operate, we have a threshold of over 35 BMI without comorbidity and over 30 BMI with comorbidities. However, the latest IFSO ASMB guidelines suggest that you can actually operate on Asians who have a BMI of 27.5, over 27.5 with comorbidities. The only thing is that they have not clearly defined who these Asians are, because now you know that you have the Mongoloid races, especially obesity is quite common in countries like Philippines, Taiwan, and so on. And we are actually more like brown Caucasians. So we don't really know whom they are specifically referring to as Asians. I feel that they are referring to those Mongoloid races. So, so in general, right, we take it as 30 and 35. That is 30 with comorbidities and over 35 without comorbidities. Earlier, it was 35 and 40, but evidence has shown that it is beneficial to operate at these BMIs. Next slide, please. The other thing is that now actually the definition of obesity is excess body fat. It's not purely BMI, because we know that if you take bodybuilders, right, they have a very high BMI, but we don't consider them as morbidly obese. At the same time, other dimensions like waist circumference are also considered to be important. However, in general, most of the guidelines have been set against the BMI. So when it comes to bariatric procedures, we have the restrictive procedures and the malabsorptive procedures. The restrictive procedures currently in use are intragastric balloons, which is an endoscopic procedure. Then we have the laparoscopic surgical procedures like banding and sleeve gastrectomy. When it comes to malabsorptive procedures, we have the Roux-en-Y gastric bypass, the mini gastric bypass, the single anastomosis duodenal ileal bypass, which is combined with a sleeve, and also the duodenal switch. Next slide, please. So now these are the procedures that are currently in use. We have the intragastric balloon, the gastric band, the sleeve gastrectomy, the gastric bypass, the mini gastric bypass, and the SADIS, or the single anastomosis duodenal bypass. And these are the, if you take all the procedures that are being done in this world, 99% fall into these. Next slide, please. So when you take the intragastric balloon, that is the simplest procedure that one can do. It's an endoscopic procedure where we place a balloon which is about between 400 and 700 ml in the stomach. Next slide, please. Next slide, please. No. The slide after, no, the slide after the balloon. Yes. It's a day case procedure. It can be done almost as an outpatient procedure. And it is usually done under sedation. And the balloon size could go up to about 600 to 700 ml. Though generally we tend to place a slightly smaller balloon. We tend to instill a less amount of saline usually at the start. That is about 450 ml. But you can certainly go up to 600 to 700 ml, which equals about 2 cans of Coca-Cola. Next slide, please. So at 6 months, you find that there is a 20 to 30% loss of the excess body weight when you use the balloon, provided the patients also adhere to the prescribed diet. Now, these balloons are not permanent. They need to be removed. Currently in Sri Lanka, we have a 6-month balloon and a 1-year balloon. But these balloons can be kept for about an additional 2 months. So the 6-month balloon, you could go up to about 8 months, and the 1-year balloon, you could go up to about 14 months. The problem with these balloons is that some patients feel very sick and they have vomiting, and it's very common in the first few days after the procedure, but many of them are able to get over it. Next slide, please. So then we come to this adjustable gastric band. Was very popular once upon a time, and but the use of the band has declined over years. It basically consists of placing a band, creating a small gastric pouch, which acts purely as a restrictive procedure. There is also an access port which is placed under the skin, and you can inject a certain amount of water so that you can actually adjust the band depending on the amount of water that you send in. Next slide, please. So it divides the stomach into two components, two unequal components, and you can adjust it to reach the goal. It restricts the amount of food and stimulates the nerves, telling the brain that the patient is full. Next slide, please. So it is the safest and simplest laparoscopic procedure at the time that it is done. It can be done as a day case procedure. It is reversible because these bands can be removed, and patients tend to lose about 50 to 60% of the excess weight, and there are no major nutritional problems because it's purely a restrictive procedure. And there is evidence in the long term that it works because these bands have been there for quite some time. Next slide, please. But there are some problems. One thing is that compared to the other surgical procedures, you get the least amount of weight loss with gastric banding. It has less effect on the other medical problems like diabetes. It's less likely to cure or benefit, and it is less likely to cure or benefit diabetes. It may take some time to achieve the best fill of the band, so you have to keep on increasing the amount of saline that you inject, which means that the patient has to be accessible. Problems are band slippage and erosion, which is quite common with all types of bands. And it has been shown that about 30% of patients have to undergo another surgery as a result of complications. So this is the reason why bands are not very popular. It's easy for the surgeon compared to the other procedures, but you have a revision rate of about 30%. Or a reoperation rate of about 30%. So next we move on to the sleeve gastrectomy. And if you take worldwide, this is the procedure that is now being most commonly performed. It consists of removing a sleeve from the greater curvature side of the stomach. Next slide, please. and the patient is left with something like this. Next slide, please. It's done under general anesthesia. It's a laparoscopic surgery. It takes less time to do than the bypass procedures. Some units like ours keep the patient generally for at least 2 nights, but in many countries it is being done as a day case procedure. It's almost like having a laparoscopic cholecystectomy. And of course, liquids can start the day after surgery, and the patients then get on for, and that is given for 2 weeks, and then the patients get on to a blenderized diet after 2 weeks. Now, this is not only for sleeve, this is the standard way in which we manage our patients. 2 weeks of liquids and 2 weeks of a blenderized diet. And of the liquids also, the first 2 or 3 days, they will be given clear liquids. And after the second 2 weeks of blenderized diet, then we take them on to solids. Next slide, please. So this reduces the amount of food that the patient can eat, because the stomach is now about 1/5 of its original size, sometimes 1/4. And it removes the part of the stomach that triggers hormone release, particularly ghrelin. So, and the food enters the small bowel quicker, and the changes in the hunger hormone indicate that the patient is full. These hormone changes help to cure diabetes, but good glycemic control occurs after weight reduction. So you don't get a much of an initial response to diabetes when you do sleeps, but once the patient loses weight, then the diabetes comes under control. Next slide, please. Next slide, please. Yes. So the problems are, this is not reversible. Sleeve is not reversible. And after some time, especially if the patient eats excessively, this sleeve can stretch. And as a result, patients can regain weight. About 15% of patients don't lose the expected weight loss. In fact, we have now a series of about 80 patients, and about 2 or 3 patients have not got the expected weight loss. The dreaded complication, of course, of sleeve gastrectomy is leak. And sometimes when these sleeves start leaking, it's like WikiLeaks. It doesn't stop easily. And we've had one patient with a leak. It was quite a nightmare, but finally we were able to do a revisional gastric bypass, and the patient is now fine. Then, of course, these patients, particularly those who have pre-existing gastroesophageal reflux disease, they can develop heartburn, more heartburn after a leak. So generally, it is not recommended for people with severe GORD. And we have solid data now only for about 10 to 15 years for this procedure. Next slide, please. Moving on to gastric bypass. Now, gastric bypass actually is an older procedure than sleeve gastrectomy. In the 1990s, it was done open, but after 2000, the world has changed to doing this operation laparoscopically. It involves creation of a small gastric pouch and then a rule loop of jejunum is anastomosed to the gastric pouch as shown in the diagram. Next slide, please. So it is done under general anesthesia. It's a laparoscopic surgery. And again, 1 to 2 night stay. Most patients have some patients have a 1 night stay, but essentially it's not ideal to do as day case, whereas sleeve gastrectomies are in many countries done as day case procedures. And again, you have 2 to 3 weeks of liquid diet followed by 2 to 3 weeks of blenderized diet after the procedure. Next slide, please. So it reduces the volume of the stomach to about 60 to 80 ml. It reduces the food intake. It separates most of the stomach from the food. There are changes in hunger hormones, so patients feel less hungry. And you do get a almost immediate glycemic control because the GLP-1 levels and the GLP-2 levels rise almost immediately after the procedure. And these hormonal changes can certainly help to cure diabetes. Next slide, please. So this gives a very good excessive weight loss. About 70 to 80% of the excess weight is lost. It is also the best for other medical problems such as diabetes, hypertension, obstructive sleep apnea, and so on. You certainly get the highest cure for diabetes, and there is sort of long-term evidence of at least 20 years for this procedure because, like I said, it is an older procedure than the sleeve gastrectomy. Next slide, please. So you tend to get more early complications than band, though band gives late complications. It is about the longest operation because it involves two anastomoses. You rearrange the anatomy completely. There is less chance of leak than with sleeve because it's a low pressure system. Patients need nutritional supplements and blood tests on a regular basis. So these patients, any patient undergoing a bypass procedure has to be followed up more closely. There is also this problem that there is loss of endoscopic access to the distal part of the stomach. So, for example, if this patient were to develop a gastric ulcer and a bleed, it is very difficult to endoscopically access, almost impossible to endoscopically access the stomach. You know that for gastric ulcers, the gastric ulcer bleeds, treatment is often endoscopic, right? So these patients will have to undergo either a radiological embolization or something like that. So that is one of the disadvantages. You can't do a complete upper GI endoscopy. You can't do a complete gastroscopy in these patients after they undergo this procedure. Next slide, please. Then we come to the mini gastric bypass. Now this is gaining in popularity, partly because the sleeve gastrectomy patients tend to gain weight after about 10 to 15 years, especially if they are not careful about their diets and if the sleeve stretches. So this is now becoming more popular. It's more popular than Roux-en-Y gastric bypass because it's easier to do. It involves only a single anastomosis. So initially, you create a gastric pouch and then you bring a loop of jejunum and anastomose to the gastric pouch. Next slide, please. So, as I said, creation of a small gastric pouch and gastrojejunal anastomosis bypassing part of the small bowel. You have to make sure that the alimentary limb is at least 300 centimeters long because otherwise the patient is likely to develop malabsorption. Weight loss is comparable and sometimes even better than the Roux-en-Y gastric bypass. And the diabetes mellitus resolution is also comparable to the Roux-en-Y gastric bypass. And for these reasons, the numbers are rapidly increasing. Next slide, please. However, there is a higher risk of iron deficiency and deficiency of other fat-soluble vitamins with this procedure. And because of fat malabsorption, there is a limitation to the quality of life in some of these patients, especially after a high-fat diet. And they tend to get bloating and steatorrhea. And also, this procedure is not very popular in the United States because there is concern about long-term bile reflux into the stomach. If you see this anastomosis, you see that there is that bile will be continuously coming into the stomach. And there is a concern because bile reflux into the stomach over a long period of time can result in gastric cancer. And these procedures are done in fairly young patients, unlike patients who already have a gastric cancer. So that is a reason for some concern about this procedure, even though it is being done. Moving on, we have the single anastomosis duodenolial bypass. Now, this procedure was recently approved in the United States as a procedure for bariatrics, as a bariatric procedure. Here, what is done is you first do a sleeve gastrectomy, right? You first do a loose sleeve gastrectomy, and then after that, you divide the first part of the duodenum and then anastomose it to uh, the ileum, keeping about 300 centimeters from the ileocecal valve. One advantage of this procedure is if you take the Roux-en-Y gastric bypass and the mini gastric bypass, in all those procedures, you take the measurements from the duodenojejunal junction. And you know that the human small intestine length is variable, right? The length in the human small intestine is variable. So in those bypass procedures, once you don't really take into account how much bowel there is downstream. But here you take the measurement from the ileocecal valve, so you know exactly how much bowel you have downstream. Next slide, please. So again, this is a procedure which is highly effective for long-term weight loss and remission of type 2 diabetes. It is easier to perform than the gastric bypass because there is only one anastomosis. It's also easier to perform than the duodenal switch, which is being now given up because this procedure is better than that. And it is also an excellent option for a patient who has had a previous sleeve gastrectomy. Let's say the patient has had a previous sleeve gastrectomy and the patient has gained weight after certain number of years. So then you don't have to redo the sleeve, right? All you have to do is to do a single anastomosis duodenoileal bypass, and then you can do it in virgin territory, which has been untouched by the previous operation. Next slide, please. So the problem with this procedure is that the vitamins and minerals are not absorbed as well as in sleeve gastrectomy or gastric banding, right? In those procedures, uh, in procedures like sleeve gastrectomy and gastric banding, you find that there is very little risk of vitamin deficiency. And the thing is, this is a NIMA operation. We have only short-term outcome data, and it may worsen reflux. And there is also, because you're doing the anastomosis only 300 centimeters from the ileocecal valve, there is a risk of more frequent bowel movements and loose motions. Next slide, please. This is a general slide which actually shows the benefits of bariatric surgery. You can see um, the insulin requirements going down with time. You also see the requirements for oral hypoglycemics going down with time. Next slide, please. So when you look at obesity surgery overall, right, you find that you get a curing of about 60 to 70% of obese hypertensives. For diabetes, it's even higher, about 75 to 85%. Obstructive sleep apnea, about 90% of patients get a cure, and in some series, it goes up to 100%. Gastroesophageal reflux disease also can be cured with the appropriate procedures like gastric bypass. The problem is with dyslipidemias. Now, this we have found even in our patients. The dyslipidemias, they don't get cured. There may be a slight reduction in the drug dosage needed, but these procedures are not so good for dyslipidemias. And there are also some studies that show that after about 10 years, you find that they have the same patients who have undergone surgery have the same incidence of hypertension and dyslipidemia as patients who have not undergone surgery. But this is only for hypertension and dyslipidemia, not for diabetes or OSA. Next slide, please. So, in summary, when these patients undergo surgery, it improves their activity and ability to exercise. Most patients can go up 3 flights of stairs. They can get back to work and get back to their hobbies. Next slide, please. Now, when it comes to cancer, about 15% of cancer deaths in men and about 20% of cancer deaths in women are due to overweight and obesity. The reason why the incidence of cancer in obesity is higher in women is because of breast cancer. Because of the cancers we know, breast cancer is the one that is most linked to obesity. And the other thing is that sometimes these obese patients tend to have larger breasts, and sometimes the detection also may be delayed, though that is not always the case. Then moving on to subfertility. Now, subfertility will decrease by about 15 to 45%. So about 15 to 45% of obese women are subfertile, and it's mainly due to hormonal problems rather than mechanical problems. And this drops to about 6% after bariatric surgery. Also, when they do get pregnant after losing weight, the complications are less. Gestational diabetes comes down to almost 0% from 22% in obese women, and preeclampsia also comes down to almost 0% from 3% in obese women. And you also get slightly better neonatal outcomes, such as premature delivery and low birth weight. Next slide, please. Now, what about weight gain after surgery? Whether we like it or next slide, please. Previous slide, yeah. Whether we like it or not, these patients tend to gain weight. Some patients tend to gain weight after surgery. Now, there are various reasons for this. There are anatomical reasons like dilatation of a gastric pouch or the outlet, right? Sometimes after gastric bypass, you find that the outlet dilates after some time, and then you find the food enters the intestine quite rapidly. And in fact, there is now a procedure, an endoscopic procedure for this called TOR, transoral reduction. And what you do there is you go in with the endoscope, and then you have this anastomosis. What you do is you first burn it using argon plasma coagulation, and then you suture endoscopically to make the outlet smaller, right? The same way with sleeve gastrectomies also, sleeves can dilate and they can accommodate more food, right? So these are the anatomical reasons for weight regain. There are also physiological reasons. Some patients may have altered fat metabolism. There are also psychological reasons, because some patients, in spite of losing weight, they continue to have depression and adaptive difficulties. Then you have behavioral problems. Some patients have lack of exercise. They have problems with eating behaviors. For example, they eat processed food, and also they eat sometimes beyond satisfaction. It's called grazing because the cows do the same thing. So these are some of the problems that you have in some of these patients, and therefore you need a multidisciplinary approach, and these patients have to be managed by nutritionists, endocrinologists, psychologists, and all these people, because to have sustained weight loss. Next slide, please. Thank you very much.
Till the time we start with the next speaker, who is Dr. Ranjita Gunwardhane. She is currently the consultant nutrition physician at the District General Hospital, Hambonta, Sri Lanka. Dr. Ranjita obtained her MBBS degree in year 2005 from Faculty of Medical Sciences, University of Peradeniya. After providing her service as a medical officer in different parts of the country, she chose her postgraduate career in nutrition by entering into the MSc in Human Nutrition program in the year 2015 at Postgraduate Institute of Medicine, University of Colombo. She successfully completed her MD in Clinical Nutrition in year 2021 and completed her overseas training at St. George's University Hospital, London, UK, and obtained her board certification to practice as a specialist in clinical nutrition, Sri Lanka. She has also completed her diploma in nutrition conducted by the European Society of Parenteral Enteral Nutrition, and she is also a TALL teacher. She was involved in the nutrition-related adults research and given technical knowledge and contributions for developing nutrition-related national guidelines by the Ministry of Health, Sri Lanka. Without much delay, I would like to invite Dr. Gunwardhane to take over the session.
So after the surgery, we'll go for the nutrition part. So I will talk about the nutrition optimization, and I have divided into a few phases: pre-operative, intraoperative, post-operative, and then long-term. I think all of you have heard about ERAS, like early recovery after surgery. So for bariatrics also, there's a ERAS guideline. So I will take you through that for the preoperative period. So if we go through the components of the ERAS, nutrition optimization is the first part, and there's also other parts like physiotherapy, psychological preparation, cessation of smoking and alcohol, medical optimization with glycemic control, and then anemia correction. So as you all know, except nutrition optimization, this smoking, alcohol, anemia correction, and also glycemic control also comes under nutrition. So we have a lot to do in that. So I want to show you some evidence regarding this ERAS. They have given, this is from the ERAS guidelines. I have taken this slide. So y'all can see the recommendations they are giving for the pre-op counseling, and then smoking and alcohol cessation for at least 4 weeks duration minimum, and then for the pre-operative weight loss, and then for pre-operative fasting time reduction, and also for prevention of nausea and vomiting. All those shows a high grade of recommendation, strong recommendations. So we have to practice those things. So behavior modification, as we all know, is the key for the pre-operation counseling. So we have to initiate with counseling for lifestyle change. Ideally should start at least 1 year to 6 months before, and you need to involve the family also. And also you have to go through the eating habits and food cravings and intake of sugar-sweetened beverages and high caffeine intake. As we have seen, all these are causes for failures. We have seen in our patients also, the patients are having all these habits previously. Later, if we don't counsel and take them out of these habits, after surgery, there can be failures. And also you have to go through the sleep, substance abuse, and alcohol use, because if there's alcohol abuse, you have to ask the patients to abstain from it at least for about 1 to 2 years before the surgery. If not, there can be failures, and they can again go into substance abuse. Also, you have to see the patient's mood and happiness things and social aspects before going for the surgery, and also in the behavior modification part. Then if you are having access to bioimpedance analysis or DEXA, then you can assess the muscle mass pre-op if available, or if not, then you can go by the muscle strength. By using the hand grip dynamometer, you can check the patient's muscle strength and have an idea about the muscle strength. In the pre-op part, you have to go for the monitoring of the vitamins and minerals if available. Sometimes those are not available. If available, you can go for vitamin B12, folic acid, vitamin D, and also iron, ferritin, and a full blood count. And also if thiamine levels, zinc, all those levels are if available, you can go for those levels. And you can optimize the micronutrient intake, and if there are any deficiencies, you can correct with supplements. And the protein intake also, you have to optimize the protein intake prior to surgery. and also advise the patients on exercise and strength training to reinforce the muscles. Then for the nutrition counseling, so this is a lifelong thing. You have to follow up is needed. So before the surgery, you have to change the patient's food intake pattern and also reinforce the ways of eating. Have to counsel on the slow eating, like after the surgery also, you have to go for this. So before the surgery, you have to ask the patients how to eat and chew food well before, and after you have to stop taking liquids with the meals. And when you are reaching the point of satiety, you have to stop eating and to take on small portions as possible, and then take it as regular intervals, like 3 hourly or so. And also to avoid carbonated sugar-sweetened beverages and simple sugars. And this training, at least it should start 2 to 4 weeks prior to the surgery. If even before that will be good. Then 2 weeks before, you go for the liver shrinkage diet with the objective of reducing the liver size and decreasing the intra-abdominal fat mass, and also lowering the surgical risk. For this, you can go for a pre-op low-calorie diet or a very low-calorie diet, usually according to the patient's requirements. And this can be started 4 weeks early, or in some patients 2 weeks early. And this has been shown to reduce the liver volume by about 16 to 20%. And when you're starting the very low calorie diet, it can be given as a meal replacement or even as a standard diet with food. And with this diet, micronutrient supplementations should be given, as this is not complete. And during the intraoperative period also, you have to monitor the fluid intake, and there should be gall-directed fluid therapy, which will be good for the anastomotic healing. Then for the post-operative management, if we go through the principles of management, early feeding is the best, starting oral, and then gradual change from liquid to solid in about 6 to 8 weeks time. And the patients should be given tailor-made plans, because no size fit all, and it varies like according to the patient's requirements. And you have to provide adequate protein by diet, and if not adequate by diet, you usually have to give supplements, because diet is not adequate in the initial period, maintaining at least a minimum of 60 grams per day, but for most of the patient, it should be more, because like 1.2 to 1.5 grams per kg per day. And also you have to provide the micronutrient supplements from day 2 itself, and aid in the physical activity and exercise also. So usually the post-op nutritional management goes into 4 stages, like initially fluids, then the pureed form, then the soft moist foods, and later the normal diet. Next. So if we go through the stages, initially post-op day 1, it's clear liquids. But no carbonated drinks, no calories, and no sugar, and no caffeine should be given. And the patient can begin sips of water. And stage 2 goes from day 2 to around 2 weeks duration. In this stage, you can go for clear liquids and full liquids. Here should provide a minimum of 1,400 to 1,500 milliliters per day. That can be divided half-half into clear liquids and full liquids. You can add the protein supplement about using whey or soy protein powders with the liquids, and per serving, it's about 20 grams per one serve. And for these full liquids, the sugar levels should be less than 15 grams and fat less than 3 grams per serving. When you go for the stage 3, that is from 2 weeks to about 6 weeks duration, that is 1 month actually. So you then replace the liquid diet with a soft pureed diet. Initially, the proteins food can be given with, you go for 3 to 6 meals of protein foods, pureed foods, because that helps with the satiety, and because after about 1 to 2 weeks, the patients are having hunger. Then around 4 weeks of post-operative time, you advance the diet as the patient tolerates. This is not a complete guide, because each patient has its own way of eating, and also tolerance is different. So this differs, this is just a rough guide. And so if the patient is tolerating the protein foods, then you can start giving well-cooked vegetables and soft peeled fruits like things. And in this stage, adequate hydration is essential, and it's a priority in these patients. And for each meal, you should consume a protein, especially initially protein, and then if they are still hunger, then you can go for the vegetables, cooked vegetables or fruits. Then in the post of 5th week life, you can go for the proteins, and if you are tolerating, then sometimes some people can tolerate salads or crackers or things like that. Then gradually change into those foods which are chewable, and then in the stage 4, that is plus 6 weeks, you can gradually introduce the solid foods and go for a healthy balanced diet consisting of adequate proteins, fruits, vegetables, and whole grains at this stage. And at this stage, you can advise to patients to eat from small plates and use small utensils to help control their portions. And the calorie needs will be based on the patient's height, weight, and age. So in these stages, most of the complications are due to the tolerance, the nutritional complications, and that they can arise from eating too quickly or simply eating too much and go for large mouthfuls if the patient is not trained beforehand, or even can be like drinking too much fluid and eating and drinking at the same time. And sometimes if you introduce the solid foods too early, then they won't be able to tolerate. And sometimes very hot and very cold foods will be an issue too. Also, a low carbohydrate, low glycemic index diet with adequate protein is an effective strategy to maintain post-bariatric surgery dumping syndrome and hypoglycemia, because these patients can have dumping syndrome and hypoglycemia. So when you are giving a low carbohydrate and low glycemic index foods are needed. In the monitoring of the post-op period, all the meal progression should be supervised in all the types of surgery, and also education is a must. And you have to supplement with multivitamins plus mineral tablets, initially like 2 per day, and calcium and vitamin D also should be given. And vitamin B12, if can check, you have to check and give to keep them in the normal range. And adequate hydration is essential. So you have to monitor all these and provide these. And also blood glucose monitoring. Sometimes they have to go on reducing the drugs for the blood sugar maintenance, because they can have hypoglycemia with the reduction in body weight, low food intake. So next is the long-term management, that is monitoring micronutrients and correcting deficiencies, and muscle loss prevention by adequate protein and exercises, and continuing healthy eating and preventing weight regain. And the patient must be stressed that this is a lifelong thing and you need to be followed up lifelong. I think this will be discussed by our next speaker in detail. So in summary, I would like to say that nutrition optimization involves preoperative counseling with behavior therapy and continuous follow-up and sustainable dietary patterns. These are my references, and thank you very much for your attentive listening. Thank you.
Thank you, Dr. Rajita. That was a very detailed and very informative presentation from you. And now we will be moving on to our next presentation. So let me just show a photo of who's going to present next. Our next topic is on nutrition and lifestyle modifications as key determinants of long-term success after bariatric surgery by Dr. Aruni Malwata. Dr. Aruni is a clinical nutrition physician and board-certified lifestyle medicine physician, currently serving as the consultant clinical nutrition physician at the National Institute of Infectious Disease in Sri Lanka. Dr. Malwata possesses a robust academic and clinical background, having recently completed a fellowship in clinical nutrition at bariatric surgery, Rochester Regional Health, New York, USA. Her work focuses on the integration of nutrition into lifestyle medicine to prevent and manage chronic conditions. She is actively involved in the multiple research projects at the Rochester Regional Health, New York, and Western Carolina University of USA. In addition to her clinical practice, Dr. Malwata is a visiting faculty member at both Lincoln University College in Malaysia, Sabaraga, I'm sorry about my pronunciation on this one, Sabaragawuma University of Sri Lanka, Postgraduate Institute of Medicine and Faculty of Medicine, University of Colombo, where she imparts her expertise to future healthcare professionals. So, Dr. Malwata, we are hoping that this evening you would impart us with your expertise in this region. So handing over to you, Dr. Malwata. Let me just close sharing my one so you can share it. Yeah.
Can you see my screen?
Yes.
Yes, ma'am.
Am I audible?
Yes, ma'am.
Thank you. Thank you, everyone, for being kind of spending excess time just because of this little technical stuff. And thank you for the introduction. And I do not have any disclosures. My outline would be lifestyle medicine and lifestyle modifications. What is the rising obesity rates currently and poor lifestyle modifications, and what will happen after that? Mainly you will have to go for the repeat bariatric surgeries and lifestyle changes in South Asian region where we get affected. How to establish lifestyle benefits and in bariatric surgery and how to follow up with a proper care plan. So the lifestyle modification, I would say, is evidence-based strategy where the whole person is focused and implemented prospective lifestyle changes. Actually, let me repeat it. It is intensive therapeutic lifestyle changes. So this is little bit different from whatever you feel about the lifestyle, because sometimes people think, okay, it's a little bit of exercises here and there. Whenever you feel like, you just go and do some exercises. It is not intensive therapeutic lifestyle changes. It is a kind of evidence-based terminology. It has its own intensity and the dosages that is necessary to be followed up. So the main objective is to establish patients' self-management and self-care, empower them with a lot of lifestyle skills. At the end, we expect to restore health. It's not little bit of, it's not simply reducing your blood sugar, reducing your blood pressure or isolated focuses, but it is the complete health restoration. We try to achieved through lifestyle modification when it is combined with the bariatric surgery. So the newest data, it is pouring over. This is from the World Obesity Atlas, the newest one. You can just see it is skyrocketing. The rates are, in next 10 years, we are in a great danger. So at the same time, I would focus here about the grade 3, class 3 obesity, where the bariatric surgeries are the best way of treating that kind of obesity, not the diet, not the simple one medications and all. Bariatric surgery has a lot of benefits beyond the weight reduction. So I would like you to see the rising trend, then again skyrocketing, hitting the ceiling. Even the percentage-wise, it is the normal. The count-wise, it is really, really high. So the Southeast Asia, our region, it's not really doing good. You can see almost all the childhood obesity rates are rising. So you can see that half of the countries in the Southeast Asian region have over 1 million children with obesity in next 5 years. At the same time, our friendly neighbor India is going to have over 27 million children with obesity in next 5 years, representing the over half of the children with obesity in the region. At the same time, it will contain obese children of 10% of the whole world in India. So these things are little nice to know things, and we have to focus our attention just not to read the numbers and forget about it, just to act vigilantly and carefully with lot of passion, because this is skyrocketing. You can't just stay away and rest. So this is our region. We are not really doing good. You can see that we have all our SAPEN 7 countries have topped the list. We have topped the list. We have come to the top 20 countries. All 7 of us are rapidly increasing obesity rate. So what does that mean? So that does mean how our lifestyle has changed. That's why we are rapidly increasing as a region. It is not the Western world. Western world do have problem, and they did have problem. But we, the thin, sick, obese people, with lot of other non-communicable issues, and with our economical background, we have to think about our lifestyle modification more than this. So it is wonderful opportunity for us to learn this and practice this all together. So the rates of bariatric revision surgeries, I have just picked these things from the recent most data from the most reliable and world accepted registries. This is the IFSO and ASMBS numbers of revision surgeries. Revision surgeries are the surgery, bariatric surgery done after the first bariatric surgery. That means once you undergo your first bariatric surgery for some reason, because multifactorial causations of the obesity can reoccur. So then they have to undergo second or third surgery. Sometimes during my learning period in US, I have seen there are some patients who undergo for their fifth bariatric surgery, which is the situation is not really good. So in this scenario, you can see the revision bariatric surgery rates are somewhere around 20%. That means that every person who has undergone their first bariatric surgery, 20% of them will come again with some reason and gaining weight. So are they really failed, or is it a problem? What do you think? Someone might think, oh, it's really bad and they have really lost the use of this surgery. It is not really that so. I would just say our recent most research that we did in our Rochester Regional Health, where we concluded, although these patients have gained weight after their first surgery, that's pretty obvious. Yes, they have come to the previous weight, but they are metabolically healthy. That is something very interesting. They have had their gut wiring, which is GLP restructuring and hormonal integration has happened in a way that it just clean the patient's metabolic environment, where we find with very heavy patients, they would have fantastic lipid profiles, fantastic blood sugar in some proportions of patients. Our study is yet to publish, so you will read that paper in future. So the bariatric surgery in this scenario is a very powerful tool, but unfortunately, it's not a cure. The whole spectrum of gastrectomies, I mean, sleeve gastrectomy, gastric bypass, single anastomosis, duodenal sutures, and the newest kid in the room is transoral reduction, outlet reduction, which is the not very many centers does it, but still that is a very wonderful surgical technique where you don't have any cuts, it only through the oral cavity. But still, all these modalities might have a kind of good, all these modalities will have definitely a good weight reduction in initial phase, but it doesn't have anything to do with keeping your weight low, because it has no relationship or no skill to keep the weight low. It will definitely come back and it will rise up if you really do not follow your lifestyle modification. So it is very important to focus on the lifestyle behavior change and start this well before surgery. The previous speaker emphasizes that it has to be somewhere around 6 months to 1 year. So maybe that's a very reliable and that's realistic number, but whoever who comes to our unit, what is important is to motivational interviewing them and improve their personal skills to handle their own lifestyle pillars. So the lifestyle pillars, there are 6 of them: nutrition, physical activity, substance use, healthy relationship, stress management, and sleep. So that's why most of the bariatric centers in the world, including the one I have worked for 1 year as a clinical fellow in advanced clinical nutrition and bariatric surgery here, with the best equipped equipments, they do the robotic surgery, and the best available equipments and the technology in the world, still they pay similar attention to the lifestyle modification. So that's very interesting. Even though they have all the hi-fi stuff, they do not disregard the lifestyle modification. In fact, our surgeons did not operate on patients who were not lifestyle-wise successful. They really postpone the surgeries and they wait until the patient get into the correct track, because it's not really the earning money, it's giving the best to the patient. So that's a very good thing to learn, and it is interesting to learn and see how much effort they pay for this lifestyle factors, which I'm going to speak about in next few slides. So this is a journey. This is a journey of lifestyle modification. Surgery lies in the middle, and this is, you have to just hold their hand and drive them through this journey. Actually, the patient is sitting in front of the car. He should drive his own car, not us. We are not drivers. We can't do anything about that. They have to do that on their own. But we are very carefully watching and looking and helping, just like someone sitting behind the seat, back seat. So they will, and the team should help them to empower and have more and more skills with regard to the lifestyle. So the key is empowering patients with life self-management and self-care skills. So we have special concerns in lifestyle modification when it comes to the pre-bariatric care. So we are very strict with some things like substance use, including alcohol, problematic eating behavior, binge eating and loss of eating control, food grazing habits, food addictions, sedentary behavior especially, and self-harm and suicide. There's a special reason for that because there's something called neurogenetics of reward deficiency syndrome, RDS. So what happened is every patient who is obese has a reason to be obese because they were having some food addiction, so large portions patterns, and some kind of food has been doing something to reward their dopamine system. So once the surgery is done, they can't eat a lot. So they have to stay away from that dietary reward system so that they need some kind of dopaminergic stimulation. So just like the previous slide shows, they have to find something from alcohol, some kind of substance abuse, maybe a food grazing behavior. So the slightest possible patient to be fallen into that trap will definitely do that. So you can see there are some genetically predisposed individuals where they have this in their genes. So we can't just do the genetic studies on everyone. So for that sake, we are very strict with our selection criteria about this. So we have very strict policies and very strict lifestyle bottom lines for them to fulfill to come for the surgery. So of course, it is 6 pillars that we are going to strengthen in the patients. The first is nutrition. So I'm so happy that this is how we did our patients guide, and we asked them not to eat any falsified food. We wanted them to eat real food. What we ask is, please eat real food. Real food comes from the nature, from the God. So directly from the nature, directly from the dairy farm, directly from the butcher. So that doesn't come from anywhere else. No factories in between. Nothing should happen to the food in between. So this NOVA classification, first group introduction has to be very understandable to the patient. Otherwise, if we just take the terminologies and just put the theory, it will never happen. So you should ask them, don't eat anything that your grandmother doesn't recognize as a food. Just put it into the simple words to make it very clear and interesting. So that's how we just want our patients to stick to the NOVA 1 and 2, not anything else, definitely not 3, definitely not 4. So those are really whole food. And also, we are very strict with the fructose meals. Unfortunately, we do not ask them to eat fruits because fruit sometimes patients do exceed the limits and it will cause really a bad dose of very high sugary intake in food patient. So, and at the same time, we should give them a task to, as a preparation for the surgery, we give the goal of getting 15 kilos or 30 pounds weight loss is definitely expected. So other than that, the structured programs lengthens up. So these mindful eating, regular meals, and all these things, not simply restricted to the words. We really take a good history and we just put them into a very structured programs like STRIVE program, which is 7 weeks behavior modification program for the food related disorders. Anyone from anywhere from the world can participate this kind of programs, even from our region, because this is happening totally online. So the patients are welcome and patients are given the best of the best, and up until they get the ideal goals reached. So as I told you earlier, you can see this is our food plate and we should give them enough fiber diet. We should let them transform their gut microbiome into a better version. So that is being done through lot of vegetables, dark greens, and colorful vegetables. You can see we ask them to eat 2/3 of the plate with vegetables, and whatever your carbohydrates and proteins can be taken in the other rest of the 1/3 of your plate. So that simply means do not eat lot of carbs and do not stimulate your insulin resistance, and we try to give them insulin sensitive diet and make it more healthy. So the exercises, of course, the second pillar, and physical activity have a lot of benefits. Aerobic exercises, muscle resistance has its own demarcations, like 150 to 300, 2 days per week, like. So 300 every day, and muscle resistance 2 to 3 days per week, half an hour per day. Of course, you know those things. And practical and sustainable plan is the must. Sometimes patients are very immobile, so you have to understand their current status and start from there, take them up and run the program. So the substance abuse is very important, and we have to follow a zero substance policy, as we correctly said, to prevent the transfer of addictions, we can't have any room for that substance policies. So we follow very strict follow-up, serum level checks unexpectedly from the patient. So then this has to be stopped. Unstoppable patients, you have to put them into programs as such, and they have to be followed up with great care to get them successful. So the psychiatry referral and clearance from them is the other lifestyle factor, because some people have a lot of childhood adverse experiences, life adverse trauma effects, PTSDs, depression, anxiety, and so many psychology-related factors. Because if you really think, obesity is a water-containing, let's say, a reservoir, there are so many channels feeding this reservoir. So if you really want to empty this reservoir, you have to completely stop these parallel and surrounding channels. So these are those channels. This has direct relationships to the obesity. So this is how we stop them with proper programs before they get into a relapses and unsuccessful results. So the sleep, of course, we do understand that most of the obese patients do have sleep problems, and that's why we apply sleep hygiene measures, sleep restrictions, sleep routines, very terminological, technological, simple, non-expensive measures to improve their sleep. Plus, if the patient is on a CPAP, sometimes they do not use it because it's a little bit of cumbersome process. We promote them to use the CPAP, and we are very pretty sure once they undergo surgery, it's well evident that they will get rid of their disturbances. So therefore, it's a matter of making them sleep well before the surgery, at least 7 to 9 hours, because it is very important to have a good sleep hygiene and good sleep routine before the surgery. It improves immunity and so many other functions in the body. So the long-term follow-up, of course, the looking after the patient within a proper program. So it's not very difficult, not very expensive. None of the lifestyle factors are expensive. Our regional countries, I mean, SAPEN region, all the countries can follow these lifestyle factors in a very stringent way. The problem is not like the Western world. We have very low threshold of these lifestyle pillars, because they are not to be paid, and likewise we don't take enough care about it. So I would plead and I would expect and ask you to just pay more attention, because the success lies in handling all these pillars and self-management and self-care achievement through intensive therapeutic lifestyle changes. Please let me repeat that. Intensive therapeutic lifestyle changes has its own dosage, own way of doing, has its demarcations. It's superior to any kind of medication to establish your lifestyle. Thank you very much.
Thank you, Dr. Malvatta, for such an informative sessions, and I beautifully covered the lifestyle modification and how important their role, especially after the bariatric surgery, because most of the time patient get relaxed and then, because the weight loss is done, so they tend to off track. So very well shared information. Now I would like to invite all our esteemed speakers, Dr. Harshini, Professor Ishan, Dr. Ranjita, and Dr. Aruni, and of course, Dr. Renuka Jetisa for question answer sessions. I know we all are running a little late of time, but let's have a one or two questions. I think one question from the audience is already answered in the chat box. Hence, without much delay, I'll go to the another question. Any one of you can feel comfortable, can give the answer. So my question to the esteemed speaker is, why is preoperative nutrition optimization is important for patients undergoing metabolic surgery? So why preoperative nutrition optimization is important?
Can I answer that?
Sure, ma'am.
Yeah, actually, yes, it is the first pillar of the lifestyle modification because as a prehabilitation measure, you really have to have a strong body, strong muscles, and strong immune system to undergo a surgery, basically any surgery. But at the bottom length, I believe that nutrition is the key factor where all the other lifestyle factors are holding, because people do not get the stress is related to the food, sleep is related to the food. So likewise, nutrition is a very nice core content to integrate with other lifestyle pillars, and it is a very basic thing and a must control thing when it comes to the bariatric surgery, obviously. So that's maybe the first very reason for the everyone who undergoes bariatric surgery can't just forget about their nutrition. They have to just be compliant, and that's why we are giving them a target to lose, okay, this much of weight. So then they have to follow. Weight loss is not possible without diet plans.
Right. So I completely agree to you. And here also with our patients in India, Mumbai, it's very critical where patients with obesity they have some micronutrient deficiency also, like vitamin B12, vitamin D. So it is very important for us to assess that before the surgery, correct this deficiency. It will also help to reduce surgical risk and supports better wound healing. And it will also alter the nutrient absorption that will occur post-operatively. So this is important. And moving to the next question, what are the very prime or key nutritional goals in the early post-operative period following metabolic surgery? So after the surgery, what will be the key nutritional goals in early post-operative period? Anyone from the?
Yeah, I think I will go with that question.
Yes.
I think post-operative period, initial goal is the hydration. You have to maintain the hydration. Then you have to think about the protein intake. That is why from day 2 onwards, you are going for full liquids and then proteins. And from day 2 onwards also, you are going for the micronutrient supplements, I think. So all these are quite essential. So you go with the hydration, protein, and micronutrients. And
completely agree, ma'am, because protein definitely will support your healing.
yeah.
Preventing dehydrations is equally important post-surgery.
Yeah.
And I think with
Post-surgery,
this,
hydration, anastomosis, and
micronutrient supplementation is equally important. And we also here take care of that. We have to avoid a dumping syndrome.
yeah.
So because by following stage diet progression, so these are, I think, 4 key important factors for early post-operative nutritional goals. Thank you so much, ma'am. Over to Ashia, if you have any questions for the speakers.
Yes, thank you very much to all of you. It was a very nice session from all of you and very informative. My question is there a chance of weight plateau after bariatric surgery? And if there is a weight plateau, how are we supposed to treat them?
Yes. Then again, the weight plateau happens due to multiple reasons. Maybe the ideal expected weight not achieved by about 15% patients, as Professor Ishan correctly said. So other than that, most of the patients do fall into different lifestyle habits. So it is basically the problematic lifestyle modification, I would say. But at the same time, as I told earlier, it is not the complete loss of your benefits. You have been metabolically benefited because of your first surgery. So this is happening due to multiple factors and non-compliance of the lifestyle pillars by the patient.
Okay, thank you so much. From the audience, if anyone has a question, they can unmute and ask the question, or they can raise hand so I can unmute for you. And that's all from me, Datta.
I guess there is no question, but still, I will wait for 1 minute. If any audience would like to have any questions, please unmute yourself and ask the question. I'm just hearing the very well lecture comments from all the speakers in the chat box. So really would like to thank speakers. I guess there are no questions. I would
I'd like to make a
request.
comment.
Yes.
Congratulations, Daruni. You gave a great talk. Congratulations
Thank
for
you.
having
That's
this.
my supervisor in Rochester Regional Health. I'm so thankful. Yeah.
It was a great session. So congratulations to the speakers. But I'd like to add one thing about weight gain. Now, if you on the subject of weight gain, our body's adaptive or defensive mechanism to any sort of weight loss intervention, whether it be lifestyle change, whether it be medications or surgery, is to try to bring it back to what is called the metabolic set point. So hitting a plateau is not unexpected. That is our normal body's defense mechanism. So the key component is to understand that there is going to be some degree of weight plateau and weight gain, but to maintain that weight loss over a longer period of time. So you're not going to, if your weight nadir is 80% of the excess body weight, there's a potential for you to regain 5% of it back, but to maintain it at that regain 5% is the trick and the key. And also, it is also important to understand the difference between weight regain, especially after metabolic bariatric surgery, versus comorbidity, the comorbidities coming back. So those two things are a little bit different because, as Aruni said, there is a if someone has started off with a BMI of 40, lost down to a BMI of 30 and regained back, let's say, to BMI 40, they still have the metabolic impact of bariatric surgery, which is they still have increased secretion of GLP-1, GIP, peptide YY, adjustments in leptin, and all of the other hormonal milieu, that their metabolic profiles are better than if they never had bariatric surgery, despite the weight gain. So I just thought I'll add those things in, but wonderful conference, and I thoroughly enjoyed listening to all the speakers.
Can I suggest something else? Because this is Dr. Jayanti from India.
Hi, Jayanti. Thank
Hi,
you.
Arnivad. It's a wonderful talk. It was pleasure listening to you and about all the speakers also. I just congratulate all the speakers, and it was a wonderful, talk by everybody. I just wanted to add one point because I had a lot of experience with, Arnima knows that I just had an experience with the bariatric surgery point of view and a lot of patients. I just want all the young budding dietitian to, whoever is senior dietitians and young dietitians who's working in a hospital need to establish a protocol of seeing the patients pre and post bariatric patients as 3 months, 6 months, and every month, every 2 weeks after the bariatric surgery, and please continue to follow them, give them the nutrients which is really required for them, and follow-up is very, very important, and you need to have a definite key nutrients which is going to helpful for them, and it has to be practiced every month. Follow-up is very, very important on these patients because to see the good results on weight reduction, so they never gain back the weights. Because I worked in a Gulf country where they used to regain the weight very quickly, but when you just tell them, when you counsel them more and more, they could be able to do everything. And I had seen almost 75% of the patients have achieved the target weight, and then they never gone back to regain the weight again. So I just wanted the young dietitians and the senior dietitian to establish the protocol for their own units. It's going to be helpful for the patients as well as to the society. Thank you.
Thank you so much taking your advice. And we have one person raising hand. Tasmiha, would you like to ask a question?
Yes, ma'am. So recently I have read an article regarding bariatric surgery. So there it says bariatric surgery alters the secretion of peripheral hormones, which is ultimately lead into depression and more suicidal thoughts. So and also rapid weight reduction. Rapid weight loss activates the hypothalamic pituitary adrenal axis, promoting continuous cortisol release, which is associated with a higher risk of depression and suicide. So this is a psychiatrist statement. So University of Sao Paulo, Brazil. So can you comment on this, please?
Yes, you are correct because there's a quite a profound possibility of the depression, anxiety, and psychiatric disorders to be expanded if they are really predisposed. I mean, something like suicidal thoughts. That's why we are so careful and so vigilant in asking that little bit of bits and pieces of information, although it's not very pleasant to be asked and dig into the long history parts. But it is very important why this after bariatric surgery, there's a tendency that the psychological changes shift into a depressive mode where the predisposed personas are at more vulnerable state. But if you really have the proper therapy, proper counseling, proper psychiatric referral and clearance from them, so those are the little tips and accurate details that we get from them to make sure that they do not go into the adverse decisions like suicidal thoughts, and the bottom line is not really as bad as to be get a worse result.
Involvement of multidisciplinary team is very really
Exactly.
Helps these patients.
All right. We have Dr. Renuka raising her hand. Doctor, would you like to ask a question?
Actually, I just want to emphasize on what Aruni has mentioned because I think Dr. Veera Singh is also there. So that's the reason now in US, they have to undergo the pre-op mandatory psychiatric counseling. So now if it is not some centers, I think they don't allow to happen this bariatric surgery because this is the must. I think our countries also, we should really kind of promote that, and then to have a psychiatrist into our bariatric teams. That is very much important.
the regional issues we had with those problems, because the US centers where I had worked is very strict with these lifestyle factors. They are really zero substance policy, and adverse childhood experiences and all the psychological problems are settled. So likewise, but in our country and maybe the other countries in the region, we can't do the alcohol and substance levels freely in each and every patient. So those things are limiting factors which we have to find ways and other means to solve, how to get those information for the better patient care.
All right, so with that, we will be moving to the next one, and that is vote of thanks. Vote of thanks will be brought by Mr. Prem Kumar Neopane, Senior Registered Dietitian from the National Referral Hospital of Thimphu, Bhutan. And Mr. Prem Kumar had his BSc in Food and Nutrition in Dietetics. He also has a diploma in General Nursing and Midwifery. And at the moment, as we are speaking, Mr. Prem Kumar is pursuing his Master's of Science in Epidemiology in Prince Songkhla University of South Thailand. Prem, over to you. Prem, I think you're muted.
Good evening, all.
Oh, yeah.
Am I audible? Hello.
Yes, we can hear you now.
Hello. Good evening, all. I would like to make an apology note that for not being on time, I got a little late, was engaged with some other task. To keep aside my personal thing, uh, yeah, it was a very enriching session going through all the talks. And if I have to go by stepwise, first of all, I would like to express on behalf of SAPEN, I would like to express our gratitude to none other than Dr. Renuka Jayatissa Madam for her ever welcoming speech, and as well her efforts in introducing our moderators. Then going to the next, our first speaker, Madam Harsani, who spoke on the overview of nutrition and medical management of obesity. So in which we were like the participants and the attendees were enlightened with all the insights on what are the rules of some medications that are used in managing obesity and overweight before having to resort or like opting to go for bariatric surgery. So it was very enriching, and we could gain and enlighten our knowledge on those areas. And to continue, the next speaker, the following speaker, Dr. Isan, Professor Isan, it was very another enlightening and very thoughtful, insightful session. Uh, in which doctor was mentioning on and elaborating on the overview of bariatric surgery in the management and treatment of morbid obesity. So doctor was kind enough to like enlighten and explain on the different cutoffs cutoff point used to define and classify as morbid obesity across the region. And at last, he was mentioning that in the Asian population or the Asian populace, it is that with 27 or zero point 0.5 and higher BMI with some existing comorbidities is a cutoff point to be considered for bariatric surgery. So there he was also, as a diet and nutrition professionals, we were also enlightened or enriched with the knowledge that there can be patients opting or undergoing bariatric surgeries are at greater risk of having micronutritional deficiencies owing to malabsorption and all. So that has to be also noted, and I'm sure like me, everyone attending the webinar has got that insight, uh, so that the task that lies ahead of us is to be extra careful in assessing and managing or treating the micronutritional nutritional status of the patient, if there be any. And the subsequent speaker, Dr. Rajita, she was talking and she was delivering on nutrition optimization for metabolic surgeries, so which was also a very relevant and very enlightening session too, because just having a patient undergoing bariatric surgery, that it's not the end of the journey. So it also involves the pre-operative nutritional assessment and management, intra-operative or during the procedure, the roles and the responsibilities of nutritionist or dietitian as a professional, and also the nutritional requirement of the patient has to be catered well, so as to have a better outcome, also to promote the early recovery following the surgery, then to have a long-term goal. Just undergoing a surgery and forgetting everything, it's not the main goal of all the health professionals and all of our thing. So that is why now having a nutritional concern, pre-operative, intra-operative, and post-operative, especially for the long-term goal, so as to not regain the weight issues, as well as also curtail the risks associated with the chances of NCDs affecting the person who has undergone bariatric surgery. So all these topics and all these aspects has been clearly mentioned and covered by Dr. Razita. So we'd like to, from the thing association SAPEN and its all the thing officials, we'd like to once again express our sincere gratitude for your time and your thoughtful sharing your thoughtful ideas on this very important topic. And the last speaker, Dr. Aruni, who in fact did a wonderful job by not just mentioning about the pre, post, and pre, intra, and post nutritional aspects uh, in cases of well, we are dealing with bariatric surgery and all, but also she has very thoughtfully and very elaboratively mentioned about the importance of lifestyle modification, not just ending to the bariatric surgery and living the journey ahead of a patient life, just having a surgery being successful. But the most important thing is now to prevent the uh, regain of weight following the surgery. So that's only possible through the a very robust team approach, and one of the primary component she was the Dr. Aruni was highlighting was lifestyle modification. Of course, that's I truly agree with that, and lifestyle modification is indeed without a patient having to resort to be diagnosed as a morbid obesity, we can even before opting or before resorting to undergo bariatric surgery, as a general healthy human being, we can always think of preventing all this obesity, overweight, and NCD epidemics just by adopting or like following the steps of lifestyle modification. That's a very cost-effective preventive approach, which we all can advocate, promote, and take it to its higher rates through counseling, through multiple communication with patients and all. So, and the last, it had a very positive impact in preventing weight regain, especially for patients who has already undergone bariatric surgery due to metabolic morbid obesity or some other existing comorbidities. So lifestyle modification has a very important role, and that including myself, everyone who has just attended this very enlightening webinar has would willingly agree to this. And I would like to also my express our on behalf of SAPEN heartfelt gratitude and appreciation to all the moderators, Madam uh, Ashia, Madam Datta Patel, and Madam Malika. So all of your efforts has made this webinar a very successful one. And the only one suggestion I would like to make, maybe like it was never thought, never it was never thought before. There was an issue where like more attendees could not be thing accommodated for the meeting, and there were lots of thing pleas and requests from other members who were keenly and waiting to join the meeting. So maybe next time onwards, we can think of attending or accommodating more members for the meeting. Thank you. Thank you once again.
All right. So with that, we will end the meeting. Thank you, everyone. Sriyani?
Yes, Asia. Now shall we end the meeting? So thank you, everyone. Thank you, Asia, and everybody who have joined today.